Today I'm going to talk about motor fluctuations and dyskinesias in Parkinson's disease. So as Parkinson's disease progresses, in the early stages and phases, medications that have a dopamine function, primarily carbidopa, levodopa, work quite well, and patients get a lot of benefit from that medication. But as time evolves, and for everybody, it's a little bit different as to when they start developing these symptoms. For some, it may be 2, 3 years. For others, it may be 7, 10 years later into their disease. Patients start noticing that their medication is not lasting as long as it used to. And maybe in addition to the medicines not lasting as long, they may overshoot or undershoot and get abnormal extraneous movements, what we call dyskinesias, which is kind of an irregular twisting, turning, wiggling type movement that patients get. Now, this is a pretty normal phenomenon in Parkinson's disease as the disease progresses. And everyone develops a different variety of these symptoms. So some may have mild dyskinesias that are not bothersome, while others may have very bothersome and limiting symptoms. When this happens, we start adjusting medications. First, we may try to give you less medications more frequently, or you may need to take more medications per dose to try to get good symptom control. We also have long-acting versions of carbidopa, levodopa on the market that could help smooth out that response, make it a little bit more predictable, help it last a little bit longer. Medications such as Rytary or Crexont are the two primary long-acting medication in the pill form. We also have a levodopa infusion called Duopa therapy. This is a gut tube that will infuse levodopa continuously over 16 hours during the awake day. In addition to that, for some patients, those medications kind of stop suddenly and unexpectedly. And when that happens, we also have what we call rescue medications. Primarily, the two that are available are Inbrija, which is carbidopa, levodopa in an inhaled form, and Apocan or apomorphine, which is a variant of a dopamine medication called apomorphine that is injectable. And you keep it on hand, kind of like an EpiPen, and you or friends or family can inject you to try to get you to turn back on and have that good positive effects from the levodopa. Now, as patients transition into this phase of more unpredictable kicking in, more unpredictable duration of benefit, we start thinking about more longer term strategies, primarily deep brain stimulation for Parkinson's disease. This is quite an effective neurosurgical intervention where we implant a pacemaker-like device into the brain, and we deliver some electricity into very specific areas of the brain, which help provide more stability, more predictability in Parkinson's patients' lives. Now, everybody has a variable and varied response to deep brain stimulation. So for some people, we can really cut back on medications quite substantially, and they can have a really good, stable on time. Whereas for other patients, we get a lot more stability and predictability, but we're still noticing some drop-offs and some variability throughout the day. So we still need to rely on the medication for care. But this can also help to quiet down the dyskinesias and keep them under better control. Other symptoms of Parkinson's that may be challenging, such as dystonias and tremors, may also improve with DBS. So it has a longer term effect that is similar to medication, but in a different strategy without the actual medication itself. So oftentimes, as these motor fluctuations and dyskinesias develop, we start talking to our patients about considering deep brain stimulation. Now, not everybody is a good candidate for deep brain stimulation. So some reasons why we may not recommend this is if our patients have a lot of other medical comorbidities like heart failure and other medical conditions that make brain surgery a little bit more challenging or too risky. Other reasons why we may not consider this surgery would be if our patients have pretty substantial thinking and memory problems, what we call cognitive impairment. This can really put patients at risk for having a longer term complication in terms of thinking and memory. And then another reason where it's not always what we call a deal breaker for DBS, but which would maybe make us pause and have us work through some problems before going forward is psychiatric complications like severe anxiety, depression, hallucinations, confusion. We really want to make sure that our patients are in their best health, both mentally and physically, before doing this surgery. Now, what if deep brain stimulation is not an option? We do have other strategies for motor fluctuations and dyskinesia in particular. We often use a continuous levodopa infusion during the day, which I mentioned, called Duopa. Now, this is a gut tube infusion, so this requires the implantation of what we call a feeding tube or a PEG tube, and then within that tube, we insert another tube that snakes down into the small intestine where levodopa is best absorbed. People still eat by mouth. This does not mean you cannot eat by mouth. It's just the mechanism through which we deliver the medication. The pump is external to you. That means you have to carry it around either on a waistband, fanny pack. Some people use a shoulder harness or put extra pockets into their jackets and sweaters. But it does require some attention and it does require help from another person. So Duopa therapy to get the medication cartridges connected in the morning and then disconnected in the evening usually requires a second set of hands because our Parkinson's patients are usually off their medications and not as coordinated as usual. This is a good therapy, but it's not for everybody. Now, on the horizon, many Parkinson's patients have heard of the subcutaneous infusion of levodopa. This is currently still only available in research protocols, but it hopefully will be available in the near future. It's currently with the FDA, and we're waiting for approval before we can use it. This may still be another 2 to 3 years into the future before we can start ordering it, but it is kind of the next thing that we're looking forward to take care of our patients. I'm particularly excited about it because one, it doesn't require us to put in that feeding tube. We just put in a small patch with needle in it, what we call a patch pump. And this is also a pump that's outside of your body. And it kind of works like an insulin pump where we're continuously delivering a low dose of carbidopa levodopa in through the skin. And then it slowly gets absorbed into the bloodstream and then goes into the brain where it takes effect. So there's a lot of things on the horizon. We are doing more research. MRI-guided focused ultrasound is also another therapy that we're still investigating. We're not ready to use it to treat motor fluctuations and dyskinesias in Parkinson's today. We recently got an FDA approval for MRI-guided focused ultrasound in the treatment of one-sided dyskinesias and related to Parkinson's disease. So because most Parkinson's patients are affected on both sides, I'm not sure about its application today, but what I can report is in research studies, we are exploring using both sides in a staged fashion, as well as other areas in the brain that might provide similar benefits to DBS for the treatment of Parkinson's disease. I think that's all I have to say. Was that sufficient?